What's up, guys? Dr. Mo here, digital nomad physician at digitalnomadphysician.com. Welcome to this beautiful farmhouse here in upstate New York in a city called Argyle. And we're finishing up our stay here, which is really sad. This little guy is a very old dog that we're taking care of, and there's a horse in the back that we're taking care of as well in this house sitting gig. So I had a good conversation with another physician who was kind of trying to figure out his career, and it was good. We both learned a lot from that conversation, but from it, I thought it would be worthwhile for me to kind of review some of the basics of the U.S. healthcare system. So this is going to be a little bit dull and boring, but I'm going to try to summarize it as best as I can, because if we understand it as physicians, then there's a better opportunity for us to maybe offer something of value to our patients. And in a recent series, a podcast series that I did, the Digital Nomad Physician podcast, I talked about what it means to have like a fulfilling medical career, to practice medicine in a way that we like, how it intersects with our personal lives, and everything. So you can check that out. It's a 3-part series. So to understand U.S. healthcare system, it's important to understand that everything is a top-down concept, meaning that there are for-profit interest groups which lobby for certain rules and regulations to be set that generally profit them. Insurance companies, hospital groups, pharmacy benefit managers, pharmacists, pharmaceutical companies. And Medicare is at the center of it because how Medicare decides to pay physicians and hospital groups and reimburse insurance companies, etc. Whatever they decide, it trickles down to commercial insurance groups. So we got Medicare, Medicaid, which is kind of like Center for Medicare Services, Center for Medicare and Medicaid Services, and then you have commercial insurance groups, Cigna, Aetna, Blue Cross. And then, of course, there's a lot of other payers. We got TRICARE, we got the VA. So there's a lot of other players in there as well. But Medicare kind of determines everything. And so, for example, recently, actually, Medicare decided to decrease the reimbursement of outpatient care and increase the reimbursement of inpatient care. And they didn't really make any changes, even though we've seen at least a 30 to 50% inflation in everything that you're buying, right? I mean, I go out to eat, I buy groceries, I probably pay twice as much easily. But that didn't get reflected in any of the recent updates to reimbursements. So what Medicare does trickles down to commercial interests, commercial buyers, commercial payers. And we have a system in the U.S. Healthcare economy where we base things off of ICD-10 code. So there's an ICD-10 code for everything. That's how you get billed. And there are clinical guidelines that we have to follow. So for example, if somebody comes in with a pneumonia, I must look at what the most recent Infectious Disease Society of America, the pulmonary and chest guidelines are for treating pneumonia, whether inpatient or outpatient, getting a chest x-ray, is it justified for me to get a CT scan, an MRI, bronchoscopy, etc. And all of that is kind of set based on guidelines. So a guideline comes out, now everybody's going to do that particular guideline and bill according to that. And unfortunately, the clinical guidelines are biased. They are written by physicians who are heavily paid and reimbursed by for-profit interest groups. And this is not a controversial opinion. This is a fact. And it's not a negative thing. Really, it doesn't have to be a negative thing. There are people who have certain biases, but they still create good guidelines. However, for the most part, as you can imagine, if you are a CT device manufacturer and you want your CT machine used for more brain imaging in post-concussion episodes, then you're probably going to spend a little bit of money in lobbying and say, hey, in the next Canadian CT guidelines, we think it's really important. We did our own research. Here's our research. And so we're going to there's a doctor who also believes that, so we're going to pay him some money or pay her some money to help push these guidelines out. So in a way, it's biased, and in a way, it's also sometimes clinical based. And so when I mentioned this clinical guideline, the reason I mention it is because when it actually comes to a medical malpractice case, many times the plaintiff's side will say, hey, Dr. Ashori, you didn't order this CT, and the current clinical guidelines say that you should order a CT scan for a patient that presents in this manner. And so then the clinical guideline actually becomes the standard of care. And when you don't do that, you're actually putting yourself at risk. So you can imagine that even though we think, oh, well, somebody can create a clinical guideline, doesn't mean I have to follow it. You kind of do if you want to have a safe medical practice or medical career. The other entities I want to mention is pharmacy benefit managers, PBMs. They're all over the news. You may not know about them much or have heard about them much. Hospital groups and medical groups, and of course the insurance groups. These are all very, very high profit companies. And the way PBMs have been kind of non-helpful is there's a lot of middlemen in healthcare. And so what PBMs do is they essentially negotiate the price of a drug with the manufacturer of the drug, and then they add that drug into the formulary of health insurance companies. So for example, I might prescribe fluocinolone to a patient versus, let's say, some generic form or brand name, clobetasol, and let's say they're both high potency steroids. Well, one of them is going to get flagged as super, super expensive. The patient's got to pay $900 out of pocket. The other one is going to be super cheap, but it's still not as cheap as you could have gotten it from the manufacturer directly. And so you end up paying maybe $120 for this high potency steroid drug with your insurance company. If, on the other hand, you bought that same cream cash from the pharmacy where there is no PBMs, nothing, and to make things more complicated, a lot of pharmacies are owned by PBMs, so you may not even get the real cash price. But if you go to Cost Plus Pharmacy, the Mark Cuban Pharmacy, if you go to GoodRx isn't a good example either because they're also in with the PBMs, but some of the cash-based pharmacies where the pharmacy actually gets it directly from the manufacturer, you could get fluocinolone for $7, $8. And so the fact that we're paying a premium for these same drugs that you can get for super cheap is because of these middlemen. And so PBMs are one of them. Again, I don't want to get too detailed. I'm trying to keep this short, and it's already at 7 minutes, so it ain't going to be short. The other part is the FDA. And so the FDA has unfortunately become the gatekeeper of a lot of drugs in the sense that they are the reason why drugs have become so expensive. There are very complicated stories here to unravel, and I'm not going to get into it, but you can imagine that the FDA has complete control over how the research phase and the chemical go through the proper process in order to become a medication that can be prescribed to the public. The main criticism, of course, is that the FDA maybe has a lot of biased opinions on which drugs should make it to market, which drugs shouldn't, what the process should be, and of course, there's a lot of like backdoor dealings where they say like the people who own the FDA eventually go on to become CEOs of large pharmaceutical companies. So all of that, what does all of that create? All of that inflates constantly the price of healthcare. Why? Because the more levels of complexity you can add to a system without demonstrating that the patients are getting a better result because of it, you're actually just adding more profits. Why? Because the people who are the key players, for example, the hospital groups, the PBMs, the medical groups, they get a little bit of that profit. Health insurance companies, for example, ever since the Affordable Health Care Act, can only profit like 20%. Everything else has to go back into their healthcare pool to service their members. But as you can imagine, if I just constantly increase the amount that it costs to deliver care to patients, well, then that 20% profit becomes bigger and bigger. So it is in the benefit of most health insurance groups to actually increase the cost of delivery of healthcare. In fact, the average American only stays with one particular health insurance company for 18 months or so, which means the health insurance company, it's not in their benefit, it's actually the opposite. It profits them to keep the patient unhealthy. Let's just say it. Because if they make the patient super, super healthy, and then that patient then goes to their competitor health insurance company, then that patient becomes a super healthy entity for that health insurance company. That health insurance company is going to have a lot of profits. So if anything, the health insurance company benefits from keeping patients unhealthy and having more interventions, treatments, more diseases, more of everything, in order for them to have the most amount of profits, because it drives up the cost of healthcare. I don't know if I explained it well, but it makes sense in my head. And the way you do that, the way you create that, is by creating less face-to-face time. The currency of real healthcare is trust, and you can only get that with time. I've noticed that in my own private practice. The only way I can get my patient to do what I think they should do is if they trust me. And the only way they can trust me is with many, many, many appointments, long appointments, where we talk about stuff, we're open about things, they're vulnerable, they feel like they can be vulnerable to me, I can be vulnerable in front of them. So that's the real currency, is trust. It's not your medical degree, it's not whether you came from Stanford, UCLA, or St. George Medical School. The currency is trust. And when the healthcare atmosphere gets rid of that, meaning you only have 7 minutes with your primary care doctor, and then the doctor has to do extensive documentation, and then there's going to be a lawsuit if you don't do certain things the way you should. And of course, even worse, I'm not going to get into the lawsuit stuff. You create a healthcare system that is based on more treatments, more screening, more testing, because there's very little time. So when there's very little time, all you really can do is just treat more, test more, come up with an ICD-10 code, look at the guideline for that ICD-10 code, do the treatment. And of course, that corrodes the trust of patients in the healthcare system. And so they no longer are looking for a physician who's going to be with them in the long run. The average primary care doctor changes their healthcare system 2 to 4 years. So this is all built in intentionally. And I think one could say, oh, Dr. Shore, you're just being, Dr. Mo, you're being very, negative about the whole thing. But it is in the benefit of these healthcare entities. And so unfortunately, it has become part of the system. And finally, where do Americans get health insurance? Well, about at least 50%, if not higher, get their health insurance through their employer. So if you get your health insurance through your employer, you have very little skin in the game. You don't really care how much they end up paying. You don't really care what it all involves. What are all the bells and whistles? And by these healthcare entities and the health insurance companies putting that pressure or putting the financial burden on the employer, they actually separate the patient out of the system. And so, which is really good, because then they can constantly increase the prices without the patient really feeling that pressure. Only about 6 to 7% of Americans purchase their own health insurance, meaning they go to the healthcare marketplace purchasing their own insurance. Now, of course, a good percentage comes from Medicaid and expansion of Medicaid into the Affordable Care Act. But unfortunately, that is not free. You might think that is free. That is the cost that all of us pay in taxes and in subsidies that we end up paying for other people. So my health insurance right now as a 45-year-old, 46-year-old American, if I paid out of pocket, I think it would be somewhere close to about $500. And in all honesty, I shouldn't say $500. I probably got to pay somewhere around $600 to $700 for me to have a reasonable maximum out-of-pocket expense. At $400 to $500, I would probably still have $8,000, $9,000 maximum annual out-of-pocket expense, which is absurd. Nobody can afford that. Most Americans can't afford that, let's be honest. But that's what it would cost. And the reason mine is so high is so that my payments go towards capping the payments of somebody who is 80 years old and has multiple medical problems, because their health insurance, realistically based on this current system, would probably cost somewhere around $3,000 a month, which of course they could never afford. And by putting the price, by evening out these crazy prices, in a way that is really helpful. It is kind of a socialized system within a very high profit system, but it will never work if that for-profit system just can continue going out of control without any checks or balances. So that's a little bit about the US healthcare system. In this system, it is very important to understand that unlike many other countries, we have this. So imagine here's, top and bottom. The majority of it is taken up by health insurance. There is a bar at the top, which is a cash-based healthcare system. It is operating in parallel with the standard healthcare system. Many Americans don't know about it. Many doctors don't know about it, but it is happening and it is flourishing. It is doing well, from fee-for-service, cash out of pocket without any health insurance, to going to the pharmacy and buying your drug cash, to going to another country and getting your healthcare service in that country, medical tourism, to having a direct primary care or a direct specialty care now, having all of these services given to you in cash, getting your surgery at the Oklahoma Surgery Center in cash, has created a system that is becoming more and more independent of mainstream health insurance. But it cannot forever stay independent, because in the end, at some point, many of us will end up in the hospital. And if those prices in the hospitals just keep growing out of control because of lack of checks and balances, because of all of these different players and inputs that I've talked about, then even that system can become completely unaffordable, even for somebody who's paying cash. However, fortunately, there's also alternative health insurance models that I've talked about many times. There's many terms for these things: healthcare sharing, crowdfunding. So, for example, Sedera, Zion, Crowd Health. These are some of the entities that are functioning essentially as health insurance, but of course they're not. They're just kind of risk pooling a bunch of people together and saying, "Hey, Dr. Shore, you're only going to pay $160 a month, and should something happen, you can submit your bill, $1.5 million for, renal failure and sepsis that you end up in the ICU. We'll take that $1.5 million. We'll negotiate that down to $750,000. We'll distribute it among the members, and it will still not cost anybody more than the $160 that they pay every single month." So anyway, that's a little bit about understanding the US healthcare system from my perspective. Of course, there's a lot that I left out, but I think it's a good general overview. I'd love to hear your take on it. Leave it in the comment section. Take care.